are sitting on the floor and had everybody
Okay, that's good.
crammed in
That's
that
good.
little room. That okay? Okay, no sleeping back there, y'all. I know you're in the dark and it's early. It's early. How many of you were here last week? Okay, did all of you get one of the booklets as you left? Did y'all by any chance bring those with you? Okay, well the information, like I was saying last week, that we covered on pressure ulcers, that information is in this blue book, and also what we're covering today on arterial and venous. Okay, so if you did not get one, please get one before you leave today, and know that everything that I'm going over this morning is actually in that same little blue book. Let me go ahead and show you that so you can see. These were the ones that we had, okay? And I'll pass them out if you didn't get one. There you go. Yeah, I'll just set these up here. And also these little pocket guides too. These were for instruction on the use of the wound care products. Okay, well y'all, I thought I've got this presentation put together and it follows through from the pressure ulcers to the arterial and venous. So what we'll do is just flip through those pressure ulcer slides and do a quick review, because some of those beginning slides are going to pertain to what we're doing for arterial venous today as well, okay? All right, so we know that we're identifying these wounds, classifying them according to depth and their etiology, and we know that so much about how we're going to treat these wounds is going to depend on what's causing them, right? Then understanding evidence-based protocols for management and prevention of wounds, and then how to use your appropriate products to get that outcome that we're after, right? We reviewed these last week. We talked about the different standards of care that we've got available to you, and I think I emailed those websites out to April, so if you guys didn't get them, April's got them, okay? We reviewed pressure ulcers. We talked about stable and unstable eschar. These pictures are great this morning. Got a lot of therapists in here this morning. Y'all love these pictures too. So we talked about stable and unstable eschar. When we would debride, what are the indications for that? Okay. We talked about when we see any wounds that are dry and hard. A lot of times on those heels, we talked about not debriding those heels. Those would be considered stable eschar. Well, we talked about some other times that we would not debride, and we talked about how that may be related to arterial wounds, right? So those are some of the ones that we'll talk about today.
Oops.
What
Oh, you
just
just
happened?
clicked it on the wrong thing.
Okay, so what do? Technical difficulty already.
I'll just do it.
Uh-oh.
There's a setting on that where it accidentally goes back to the next.
Oh, good. Oh, that was easy. Okay, and we also talked about how wounds are all classified as surgical or non-surgical, and then acute and chronic. So remember, the ones that we're mainly dealing with are the non-surgical, acute, and chronic. And those would be pressure ulcers, venous stasis, arterial, and wounds like that, right? Diabetic foot ulcers. Now remember this little guide here, and also know that this same little guide is on the back of your pocket guide here. So if you've got questions about those layers of tissue and how all of that stacks up, we've got it on that little handout as well. So we were talking about how wounds correlate from pressure ulcer staging to partial or full thickness. And we talked about if they were in the dermis, which would be like a stage 2, it's going to be partial thickness. If it's in subcu or muscle or bone, it's going to be full thickness, okay? So remember that, as well as today when we're talking about arterial and venous wounds too. Same thing's going to apply. So here were some examples of those partial thickness wounds. Remember? Friction. We had a skin tear, a partial thickness burn, and then a stage 2 pressure ulcer. And we contrasted that with full thickness wounds. Remember, this was a surgical chronic wound. Here we had a pressure ulcer, and everybody knew last week this was clearly a venous stasis ulcer. Okay? We went through the definitions of pressure ulcers, the different stages with the new suspected deep tissue injury. We went over all the definitions, talking about especially how a stage 2 was without slough, and a stage 2 was a serum-filled blister. Remember how we contrasted that with a blood blister? What was that considered if we had a blood blister? Y'all remember that? Suspected deep tissue injury, yes. All right, and then a stage 3, and on these we talked about, remember, how we don't have to have significant depth, because a lot of times we can have stage 3 wounds over areas that do not have subcu tissue, right? Like over the bridge of the nose and over the ear, the occiput and malleus. Remember we talked about that? And then a stage 4, we're going to see muscle, tendon, or bone, and how it was so easy, much easier to stage a stage 1 and a stage 4, but the gray area was really between the 2 and the 3. Here was the unstageable. Here was the suspected deep tissue injury that we talked about. And this is something that we did not get to, where we were going to talk about reverse staging. I wanted to be sure and cover that this morning. We didn't cover staging. If we have a wound that is a partial thickness wound, that would be just a stage 1 or 2. We can reverse stage on that. But if we have a wound that is a full thickness wound, which would be what stages? 3 and 4, that's always, it never goes back. We never reverse that stage, right? So if you have a patient that has a stage 4 pressure ulcer and you heal it, and say that patient comes back to you again for something else, you still are able to count that wound as a healing stage 4. Okay, fully granulating stage 4. All right, even if it is healed. And the reason that they do that is because think about these wounds that are stage 4 pressure ulcers. Now, if we're down to muscle, tendon, and bone, and that wound fills in, what do you think it's filling in with? Scar tissue. So non-viable tissue. So we know that if we've got non-viable tissue and that patient starts to take a dive, that's probably going to be one of the first areas that breaks down, right? Okay, so that's why on a full thickness wound, we never reverse stage.
Question?
Yes.
So if we're seeing people from admission to admission, or we get people who are admitted and have had stage 4s in the past, we should then be scoring them as
Yes, on your OASIS. That's right. And two, if you've got, because this last bullet down here, number 4, think about if you get patients that come from a nursing home, from a skilled facility. They have a little different way of documenting. Now, on the nurse's note, in the chart, it's supposed to still remain the same as no reverse staging. But to show progress on their MDS form, which is like your OASIS, they have to reverse stage. So if you are getting a patient from a long-term care, and say the intake person gets that referral, and they say this patient has a stage 2, you may want to ask, what was the worst stage of that wound? Okay? Because if it was a stage 4 and they have documented that it's now a stage 2, you still get to count the stage 4 if there's documentation for that, or if the physician has documentation of that. Does that make sense?
Yeah, we don't always get that information.
Right. And sometimes just asking that as the person is getting that referral, that's a lot of times a good way to ask. But sometimes too on that admission, well, whether or not they're going to give it to you, but sometimes on admission, have you ever gone out and you've seen a patient and you know that this patient obviously has a history of pressure ulcer by the scar? And maybe somebody in the family says, oh yeah, there was a time when you could put your fist in that thing. You know? So you know, okay, note to self, there was some injury here that we may need to investigate, because that really can equate to points that equate to reimbursement for you guys.
But Tammy, if there's nothing there, if you see that scar and it was a 4 at one time, but it's totally closed,
healed,
nothing
right.
open, not red, it's not even a stage 1 at this
Right,
point.
right.
Then
You still can. You still can.
you put down a stage 4.
Fully granulating stage 4, because, Janice, they know, like I say, CMS knows that is going to be one of the first areas that breaks down if that patient, say their blood sugars go wacky, or they get an infection, or their caregiver takes a hike. Those risk, that risk level, and that is perfectly acceptable to be able to do that.
Okay,
Yeah.
what if they've had surgery? I had a patient who had a stage 4. They did a flap. It's closed.
Once
What
they've
if
done a
that
flap,
area-
it's a surgical wound.
So it's a surgical wound. now,
That's right.
Even if he breaks down again.
Yeah. Yeah.
Could this be any more confusing?
No. And the fun part is that it's continually changing. I mean, you know, there are things that change all the time. I'm used to if there was any pressure ulcer and you couldn't backstage any pressure ulcer. Now it's only a full thickness, so that just adds a little more complexity to it. Yeah. So, very good questions. All righty. So wound management highlights, we covered these last week for your pressure ulcers. Okay, venous stasis ulcers. Let's talk about venous and arterial wounds. And a lot of times when we look at these types of wounds, it is really important on these to know the etiology and to know the why behind the wound, because that's really going to help not only to treat the wound itself, but to treat the cause, okay? Or to not to do any further damage a lot of times. Because if we've got a venous stasis ulcer, that is certain. We've got these two systems of circulation. Okay, so we've got our arterial that's pumping out this high pressured oxygenated blood, okay, to all of our extremities. And then we've got our venous system that's bringing everything back. Okay, so when that venous system fails, and some of the ways that venous system fails, a lot of times those valves that are in our vessels, as the blood is being pumped back up through the venous system, those valves get lazy, and that blood flow falls back down. It just kind of pulls down in those lower extremities. So when that happens, we get lots of the edema, lots of the fluid that seeps back out into that soft tissue, and when we see that, that's when we start to have that skin breakdown as well. So there are some characteristics that are going to be very crucial to looking at so that you can identify what type of wound this is, because that is really going to guide your treatment. Now, in your blue book, I'll show you on page, if y'all have got them with you, it's on page 10. And all of the assessment criteria is going to be in this book. And if you got it last week, know that you've got it in your possession at least. Okay? So we're going to look at some of those characteristics that will help you to determine, if you didn't already know, that it was a venous ulcer. Now remember last week we talked about the different guidelines. This is the WOCN practice guideline book for venous stasis. And for each type of chronic wound, they have a different booklet. So this is the one for venous stasis. Okay? So venous ulcers are chronic skin and subcutaneous lesions usually found on the lower extremities, at the pretibial and the medial supramallear areas of the ankle, where the peripheral veins are located. So let's look at that a little further. The locations where you may see these wounds, okay? Medial aspect of the lower leg and the ankle. So we look at this and we can see already that these edges are a little irregular. We're going to see that the base of this wound bed is ruddy. It's going to be redder, because if you think about all the blood that is pooling down in those lower extremities, it would make sense that that wound bed is going to be darker, right? As opposed to when we're contrasting these, think about these in comparison to an arterial wound, because we're going to do those next, and then you'll see the difference, because the arterial wound is going to be very pale. All right? The wound edges are going to look quite different on an arterial wound. So here, surrounding skin, a lot of times we'll see that venous dermatitis, and they have some brown staining, that hyperpigmentation. The depth, usually shallow. Wound margins are irregular. You can see that. Exudate is usually moderate to heavy, right? Those are the ones where we really have to work with managing that fluid. Okay? Edema, pitting or non-pitting. The skin temperature is normal, warm to touch, because remember, they've got a lot of blood that's down there, so those legs, those extremities usually are not going to be cool. Granulation is frequently present. Infection is less common in these types of wounds. Pain is minimal unless there's an infection there. And what about arterial wounds? Is there pain with arterial wounds? Yeah, a lot of times there's pain with arterial wounds. Their peripheral pulses, they're palpable and present, and then the capillary refill is normal. All right, so think about these types of wounds. If we've got a venous stasis ulcer and we're having difficulty pumping that blood back up to the circulatory system, what are some ways that we might help that? Compression, exactly. So wrapping those legs, whether we're doing a short stretch or a long stretch, wrapping those legs and helping that blood flow to return back up to the heart. All right? So when we do that, it's very important that we know that that is appropriate, that this is a venous stasis ulcer, and that the type of compression that you're choosing is going to be appropriate for that patient. Now, we've got short stretch and long stretch. Short stretch, for example, is like the Uniboot. All right, those are for ambulatory patients. For long stretch, like a Sure Press or maybe Pro4, those are going to be for patients that are ambulatory or non-ambulatory. And what you want to happen when you're doing those types of dressings is certainly to treat the wound under the compression wrap, just like you would if you were not going to be compressing it. And all your Convatec products allow you to be able to do that. Okay, and as you wrap that leg, of course, starting right under the toes and going up, and what we want to create is that funnel effect, so that we're going up evenly, okay, to provide that circulation back up to the heart, so that we can incorporate that. Now, by doing that, that also is going to help to decrease the likelihood of those wounds. Now, when you do a compression wrap, sometimes they can be very difficult, and of course not a visit that you guys can teach family members, right? And they can be very time-consuming as well, very frustrating. But if you've got the products to manage your wound itself, and then you're doing your compression properly, then you can get some good results. Not always. These types of wounds can be very frustrating as well. So I know I'm preaching to the choir, but let's look at some of these. Look at some of the statistics on this. Venostasis ulcers account for about 70 to 90% of all leg ulcers. And here you can really see an example of some of the macerated skin that you might be dealing with. They're more common in women than men. The risk increases with age, like everything. And then the history of a DVT, that also increases the risk of developing these types of ulcers. All right? So, what do we want to do? Treat varicosities. We want to have a good exercise program. Avoid crossing legs. How many of you have your legs crossed in here this morning? Yeah, that's right. Do what?
I have bad varicosities too, but
It's just a natural way you sit, right? So that's difficult. Compression therapy to improve that venous return. We just talked about that. Light compression may be beneficial for some of those patients. And I'll have to tell y'all, I have a brother who is 40, and he has already had a DVT. And some of the things that I see him do, like the no exercise and just lots of things, I have to scare him with some of these pictures, because a lot of our patients and family members, they can't imagine what the body will do. They have never seen wounds like this. And so when I see his leg and he's not wearing his stocking like he's supposed to, and I see that hemosiderin staining on his legs, I'm just, oh my goodness, Lathan, let's get the book out. Let me show you what can happen, brother, because I know you're going to be calling me when it does. So, like I say, if we can prevent these types of wounds on the front end, it really can make such a difference. And as we know, as we get older, as we get more overweight and our eating habits aren't what they should be, certainly all these things we're at higher risk for all of that. So, like I say, sometimes you have to resort to the pictures. Management of these wounds, and we've already talked about some of this. Certainly we're going to cleanse with non-cytotoxic wound cleanser. Avoid products that contain irritants and allergens, because a lot of times that skin surrounding those ulcers can be very irritated and sensitive. We want to debride in necrotic tissue in that wound bed. Choose appropriate dressings that are going to provide moisture, but at the same time manage your moisture so that you're not further macerating that peri-wound area. And again, protect that peri-wound area. Choose appropriate compression therapy. Like we were talking about before, so many times when we talk about the different types of therapy, like a Uniboot or a Uniflex versus something like a SurePress or a Profor, if you ask clinicians, the Uniflex patients or the Uniboot patients that you've got, are they ambulatory? Well, they may say they're ambulatory, but do they ambulate? That's something that we really want to look closely at, and making sure that we're using the right therapy. Always read your package inserts on your products to make sure that you're using those products appropriately. Alrighty? Distinguish between contamination and colonization and with infection. You may do a culture, you may not. And then certainly if you've got an infection or you think that there's a risk of infection, protecting against that or treating it, and then consider short-term, the antimicrobials there, like a silver dressing. Okay? Some of that skin management around those dry, scaly legs a lot of times, this can be very difficult to manage. Y'all can see this like a left calf. Here's their toes here. All right? And some of these are just some of our products, but y'all can use what's in the home, what you've got, whether you've got a heavy moisturizer or a protective barrier cream, something that's going to provide a lot of moisture. And also, as that wound here may exudate a lot, then that can help to protect that skin surrounding that wound as well with some of these products.
Tammy, a
Yes.
lot of folks in the home are finding Vaseline.
It's not optimal, but if that's
Okay.
all they have, then that's okay. It would be good to have a heavier moisturizer and something that's not so full of petroleum. Something like with petrolatum in it, which is a form of that. But with these types of wounds here, where you see a lot of the maceration around there, a zinc-based product is going to be better, because you see that this white cream around here, and ours happens to be the Sensicare Protective Barrier, but that actually has the zinc in it, and what that will do, it will adhere to that open, weepy, denuded skin. It will adhere to that. It will provide protection, and at the same time, ours actually has some of the little granules in it that are stomaadhesive powder that will help to absorb some of the moisture that is oozing out from that weepy skin too. So it's kind of a twofold. Then you can manage your wound with your dressings, and you're managing your peri-wound area with your ointments. Okay, any questions on that? And two, as well, you know, some of the medicated wraps, whether it's with calamine or with zinc, can be very helpful as well to that surrounding skin. So in summary, wounds cannot be appropriately managed until we know the etiology. Now, with these types of wounds, if we did not compress some of these legs, and we know that not all of our patients are going to be compliant with compression. That's very difficult. And sometimes working them in from something that's very light into something that's more moderate. But being realistic about what they are going to tolerate. You know, sometimes a little compression is better than none. So knowing that, and if you've got a patient that every time you leave and you just know by the time your wheels hit the highway that they're cutting that thing off, then you need to go to plan B. You know, we need to look at another method of managing this venous ulcer, okay? Accurate wound classifications will help you determine appropriate management. That's what we've been talking about all morning. And then certainly classifying these and documenting them in terms of partial or full thickness. So back to where we were talking about the tissue levels and the stages last week, if we have one of these venous stasis ulcers that has slough in it, is that going to be a partial or a full thickness wound? Huh? Full. Everybody said that together. That was very good. Because remember, we can't have necrotic tissue in a partial thickness wound. Remember it said a stage 2 without slough? So if we've got a partial thickness wound, it won't have slough. Okay? So in other words, if you do have slough or necrotic tissue in a wound bed, it's a full thickness.
And that's because slough comes from under the subcutaneous tissue, right?
Exactly.
Okay.
It comes from that subcutaneous tissue. It's a byproduct of that. Yes. Okay? Any other questions before we go to arterial? We're doing pretty good on time, so that's great. Boy, it seems like much fewer people this week for some reason.
It's a bigger room.
No,
A bigger room.
Everybody's a little more comfortable this morning too, aren't they? Very good. Okay, so arterial ulcers. When you look at this ulcer compared to what we just looked at, you see some immediate differences, don't you? Okay? We're going to see that these wound edges are much smoother and round. They look like a little punch biopsy. That wound bed, that looks a little infected there, and that looks a little darker than what we typically see, but I think it's because we've got some dry necrotic tissue in there. Okay, so let's take a look at these arterial wounds. Now this is going to be the clinical guideline for the arterial wounds here. Like I said, they're color coded. Now look at these. Some great pictures. You probably can't even see those toes there because they blend in with the backdrop. But all of those toes, eventually what's going to happen to all these toes? Yeah. How many of you have had sock prizes before? That's right. That's why we say look at the skin, guys, from head to toe every time you go. Take those socks off, take those diapers off, because you never know what's going to be waiting for you there. Yeah. I had a trainee that rode with me last year. He came on board with us, and he was non-clinical. He was from down in Atlanta. And I did some wound programs during the week that he traveled with me, and we were showing pictures, and I would always say that how many have had sock prizes, and there was always, just like this morning, at least 2 that raised their hand, you know. So after about the 3rd day, we were traveling back to Raleigh, and Jimmy says to me, "Tammy, you keep talking about sock prizes. Do you really mean that they take those socks off and their toes in there?" I said, "Yeah, Jimmy, that's exactly." Oh my gosh, he really could not believe that. So, like I say, I mean, people just cannot imagine what the body will do. They just cannot imagine. Okay, so these are ulcers that are caused by an impairment in the arterial circulation. So again, this circulation, this system that's pumping out that highly oxygenated, high pressure blood. Okay, and it's meant to get to all the extremities, but as a patient has narrowing of those arteries, maybe from atherosclerosis, that's probably what it is most times, a lot of times, maybe some other things sometimes, but the narrowing of those arteries, when that takes place, it doesn't allow that blood flow to get to those extremities. And so you see what happens over time. Now, managing these toes, when we think about how would we treat that, we leave those toes alone. We leave those toes alone. That's, again, stable eschar. But if we start to moisten these toes up, what's going to happen? If we don't have good blood flow there, and we've got open skin, open tissue, Infection, exactly right. We can start that amputation process a lot sooner. But if we leave these alone, that's what's going to happen. The auto amputation process will take place little by little. Now, even if they had, if there was going to be some restorative surgery there to get blood flow back, there's still not anything we're going to be able to do about these toes. These toes are gone. They're on the way out. But before we would start treating anything else, we would want to make sure that there had been some restoration there. Okay? So, let's look at this. Atherosclerosis is the most common cause of arterial disease. The prevalence, 30% over the age of 66 and older. So look at some of these examples here. And if you start to look at these open wounds, you start to see some characteristics. And certainly, like I say, that's the picture we had before. So again, now this is going to be, if y'all got your books with you, this is going to be on page 12. And there's some lovely pictures there on page 12. Those of you who didn't bring your book, you'll just have to wait in anticipation. They're good. They're good. Now, these wounds are going to be located like on the tips of the toes, on the web spaces, the phalangeal heads, around the lateral malleus, and areas exposed to pressure or repetitive trauma. Now, let's look at what these wounds are going to look like as compared to our venostasis ulcers. The wound base here is going to be more pale. Okay? Skin is a lot of times shiny and taut and thin. We've got hair loss here on those lower extremities. There's atrophy of that subcu tissue. All right? The wounds here are deeper than they are on venostasis ulcer most of the times. And the wound margins are very even. Look at this one. This looks like a little punch biopsy, doesn't it? Yeah. Okay? That exudate is going to be minimal because unlike the venostasis ulcer, we don't have a lot of fluid pooling down there. We can't get anything there, remember? So we're not going to have a lot of drainage with these wounds most of the time. Edema can be variable, but not very likely. Skin temperature is going to be decreased or cool. Again, remember, venostasis, you're going to have a lot of blood flow down there, a lot of fluid. Here, you're not going to have much at all, so those feet and extremities are going to be cold. Granulation, that's rarely present here. And infection is frequent, again, because of that lack of blood flow. So we have to be very careful with these arterial wounds. Necrosis, eschar, gangrene, that all may be present. So when we see toes like on the first slide, that's dry gangrenous material. And if we start to moisten that up, we're really going to get in trouble. Pain, a lot of times these patients will have pain. Now, venostasis ulcer patient, what do we want them to do with their legs? We want them to elevate them, prop them up. Now, with these patients, what's going to happen sometimes if we prop those feet up? They're going to have pain because the gravity helps to aid in that circulation. What little bit of blood can get down there is getting there, it's perfusing with gravity's help. Sometimes in the middle of the night, these patients wake up from the pain and have to dangle on the side of the bed just to get a little bit of blood flow down there. So if you're elevating legs and you're not sure, and they're complaining of pain, a lot of times that can be due to the ischemia. All right. Their peripheral pulses are going to be absent and diminished, and their capillary refill delayed, certainly. Okay? Any questions on these? And remember, you've got every one of these in your booklet here with some additional pictures. Again, identify those patients at risk for arterial wounds, knowing their history, knowing their labs, and you can do the lower extremity exam, manage the systemic conditions like glucose control and cardiovascular disease, certainly, and then reduce those risk factors. Patients who smoke, what does smoking do? What does nicotine do? Constricts our vessels, so every time they're smoking, that is even impairing that blood flow a little more. Obesity, we know that that's not going to help in the overall picture. And then hypertension, again, that pressurized blood flow. So when you look at arterial patients, and I'll tell you, I work home care, hospice, and long-term care. And I have a home that we have a corporate contract with, and they were new to us. And I had a call, and they wanted me to come in and work with a treatment nurse. They said they were having a lot of unusual amputations over the last 6 months. And I mean, their rate of amputations had really gone up. So went down and worked with the treatment nurse a bit and realized what was happening. She was treating all of her arterial wounds with moist wound healing. So really know that it can really make a huge difference in how you treat these wounds, because guidelines are guidelines, they're broad. But your assessment is so important because, again, if you don't know what the cause of the wound is, that is truly going to guide your management. And so if you're treating an arterial wound like a venous stasis ulcer, you can really cause some major damage. So it's really important to know that if we've got eschar, even on lower extremities, and it's dry and gangrenous and stable, like we've talked about, and you know that this is an arterial patient, the last thing we want to do is to moisten that up. So even if you are dealing with a patient, remember, if you've got an arterial wound, and infections can be pretty prevalent with them. If you've got an infected wound, certainly managing that with a silver product. But this would not be one of those patients that I would recommend leaving for 7 days. Remember, that's probably one that you want to monitor a little more closely, okay? So just because you've got a guideline like you've got here, that doesn't mean that it's just foolproof, and you guys know that, to manage this according to your assessments. And knowing that even though we say these dressings can stay in place up to 7 days, we'd never suggest that you go from day one and leave it on for 7 days. Did have that to happen one time in the 4 years here. So I always like to say, if you're doing a daily dressing change now, when you're changing to a more advanced wound dressing, instead of doing it daily, put the dressing in place that it's called for here. Go back and check it on the 3rd day. If it's looking like it should, if it's not too moist, if it's not too dry, if you don't see any signs of infection, nothing has changed, everything is going in the direction that you expected it to, repeat that dressing change. Then come back on maybe the 4th or 5th day and look at it. Get it as close to that 7-day time period as you can, safely, but never go from start to 7 days in one stretch. Okay, and I know y'all would do that. Alrighty, let's move on. We're doing good on time this morning. So management of these wounds. Seek care guided by a clinical wound expert. Determine vascular status. Cleanse the wound with non-cytotoxic cleanser. Don't debride stable black eschar. This is pretty much a review of what we've just talked about. Moist wound dressings may be beneficial for open and draining ischemic wounds with soft devitalized tissue such as slough or exposed bone or tendons. And if we've got exposed bone, what also should we be looking for as well if that wound is not healing? Osteo, that's exactly right. We talked about that last week. And then choose a dressing that allows for frequent assessment and then manage any wound infection. Okay? Indications for debridement, they're going to be exactly the same. If you see that the wound is looking infected, always we're going to be debriding, but if not, then we're going to leave it. And those are the indications for the dry, stable, and the clean viable tissue. Now, here are some examples of the stable and the unstable eschar here. Okay, these are some more of those toes. This is an up-close view, isn't it? Almost can, well, I won't say that. Okay, this is a very up-close and personal view of those toes. So this is not a wound that we would start debriding, would we? We would certainly not want to, because if we were following this guideline and not considering what type of wound this is, okay, it's dry, stable, dry eschar, we would pre-moisten Aquacel or Aquacel AG and wrap those toes up and keep it moist. But knowing that this is an arterial wound, that is certainly not what we want to do, right? Now this wound, on the other hand, this one, you see this necrotic tissue in here, that's showing signs of infection. Look at the wound bed itself, okay? That would be one that we would probably want to pre-moisten some Aquacel AG and cover that wound. Okay, but still to monitor it closely, and like I say, not leaving these wounds for the 7-day time period unobserved. Any questions? Yes?
When would it be appropriate to use betadine on what appears to be gangrenous black toes?
And some doctors like to do that, and really any other time, you know, betadine is termed as contraindicated just because it's caustic to the wound bed. But a lot of times on that stable eschar, doctors will recommend betadine, just wiping it with that just to keep it dry, you know, and to cut down on any infection that may be brewing there. So that would be a time when I would say, you know, that would be appropriate.
But is saline generally the best thing, a non-cytotoxic, you said?
For cleanser,
Yeah.
for cleanser. But the betadine is just going to help that drying action as well to keep this wound dry. Yeah.
Is there any difference using the betadine? Are there studies that if we did nothing to it other than keep it clean and dry, as opposed to using betadine?
Not any that I know of, Janet. No. No. And on those heels, sometimes, and completely nothing to do with treating infection or preventing infection, but a lot of times nurses like to use skin preps on those heels, you know, if we've got a stable eschar on a heel. And with a stable eschar on a heel, yes, we've certainly got pressure involved, and sometimes you've got ischemia as well. So a combination of those two. But really here, putting the skin prep on that because there's really no pressure and no friction usually, then you may or may not use that there. I probably would not.
Would you use safe cleanse to clean that foot, or just saline, or just nothing, or what?
Well, I would certainly clean it, and you could use safe cleanse. Yeah, you could use safe cleanse on that. But so far as doing anything more beyond that and an assessment and assessing those wounds frequently. And again, that's what we're talking about. Even if you guys are only out there once or twice a week, look at those toes every time you go, because they can change on a dime. You can have them look like this for a month, and then an infection start brewing, and that can move fast. Okay? Well, that's diabetic foot ulcers. Okay? So, any questions on the arterial or venous, the comparison there, on the treatment, any of that? One thing I wanted to mention to you guys, I think somebody had asked me last week when we were talking about the pressure ulcers, and there was a question that came up, and we clarified it with the PT that asked, but I wanted to make sure that none of you got misguided on that. There was a question about, and I think this was to do with a surgical wound, and I know you guys had that before I started last week, but Cheryl asked me to just kind of review this with you. She said that if there was a surgical wound that you all are observing, and say that it has a dressing that's intact, that you all need to request, and you all help me out here, need to request in order to look at that wound, okay, be able to take that dressing off unless it was like a cast or something else that was non-removable. But if it were a dressing that could be removed so that you could view the wound, that when you make your initial call, to ask to be able to observe that wound. Okay? Who was? Yes.
Venous faces ulcers that patients who can't tolerate compression dressings.
Mm-hmm.
Where do you go to?
Sometimes something like a tubie grip, you know, those are softer types of light compression, and they come like in a long tube, and you can cut that off and slide it up. It's kind of similar to a TED stocking, but it's not quite as cumbersome and bulky. You know how difficult they can be to get on, the TED stockings, and patients just, you know, about have a heart attack just trying to get the thing on. Well, these are much softer, and it looks like the material that, say, an ACE wrap is made out of, but it's much different because it has the elasticity that goes all around, and it's in a tube. Now, it comes in different sizes, in letter sizes according to the calf size of the patient. But those are some things that you can do. You can do that single or double layer sometimes, and that also can help to ease a patient into compression wrap. Now, something that I have, and I think I've got it in here. Let's see. I do. Sometimes patients who you're using maybe a short stretch on, like a Uniflex or an Uniboot, and that's so difficult to tolerate because it's just so stiff and hard. Those are the ones they cut off sometimes. But if you've got something, this is our Sure Press. And the Sure Press, I'm sure y'all have used this before, but this is the long stretch, and it can be used on patients that are ambulatory or non-ambulatory. And I like that just because it's safe for either. The other thing that I like about this is that it has the 50% overlap mark. Y'all can see that dark yellow, that dark gold band there. It has your 50% overlap, but it's also got rectangles here, okay, that you stretch so that you can stretch it for high compression or for moderate compression. But the thing is, I like about this is that you can maintain a consistent compression all the way up the leg. So you've got a visual, and so many times I think when you're doing a compression wrap, it's very difficult to know if you've got that on just right, or if you're overlapping just right, those kinds of things. So this is one, and the other thing too, you know, compression wraps can be very expensive. This one can be washed up to 20 times. Yeah, and maintain its elasticity.
What's the name of that again?
Sure Press. And all of these, along with our other stuff, is in the blue book here, okay? So it's got the information on those products in here so that it kind of gives you a little background. Like this one is on page 41 or 2, 42 and 43. So when you look at that, it kind of gives you an explanation of what that is, and then other information on it's in the back. But you can get this by itself, or you can get it with that absorbent padding. So remember, when you're doing that compression wrap though, you want to make sure that you've got the funnel shape. So if you've got any deformities in the leg, you know, you want to maybe work on those with your padding so that you've got a good funnel. Because, and think of this, in some of the workshops that I've done, if we do the wrap, you know, and you start under the toe and you're doing your 50% and you're doing your figure 8 around the heel, always include the heel, by the way, okay? So when you come up to the top, I've had clinicians, if they've had stuff left over, then they're coming back down. No, good. I'm glad to see y'all shaking your head. No, no. So when we get to the top, we cut it off, right? And then we tape, and we never tape all the way around the leg, right? We tape down the sides. Even some do that stirrup kind of thing with tape, and that keeps all of the layers where they should be for a longer period of time. Yes?
I don't think we carry this now, are we going to?
I think you guys have used some of it. I'm sure Myers has some of it back there. I've seen that.
We carry.
You've seen it.
We
yeah.
did, yeah.
Yeah, yeah.
I'm not sure if we still do, but we carry show press.
Well, we do the
With the padding.
cottony sure press we have. I don't know that we have that.
You have the what, Jen?
The cottony stuff.
The absorbent padding
Yeah,
that
the
we had. It
padding.
comes separate.
It comes-
Yeah.
It comes separate, so you can get this by itself because you may have a patient that does. And remember, you can wash this like I said, but the absorbent padding, of course, you're going to throw that away each time. So you can get that absorbent padding like 6 to a bag, and then these. Say if you were doing it 3 times a week. Say if you were doing this 3 times a week and you had a dressing under this, you were doing your absorbent padding, and then you were covering with this. Maybe you'd only have to have 3 of these for a month. Okay? So you'd after each use, they would wash it out, have it ready for you the next time. So that's all you would have to buy for a month because
just
like I
hand
said,
wash
20
it.
times. They just hand wash it, let it dry. Yeah.
Is that part of one of the, like a Pro 4? Is that, because I remember something that had squares on it that came with other stuff.
I'm not sure.
Huh?
We used to have that back
We
in the
did.
day.
Uh-huh.
Was it separate though, or was it?
Well,
It came in a
you
box.
had to, it wasn't widely used,
It
but
came
it's
in a box
available.
with
Yes.
the padding, and then
It's been
this
around for a good
came in the
while.
same
Yeah.
So
box
it was in
Yeah.
a box.
Yeah.
So I don't think we have that back there now.
anymore.
I haven't seen it for.
Okay. And like I say, those
Back in the day.
back in the day. Remember that? Yes, yes. I was doing those beds back in the day. Yeah, that's right. That's
So you're
right.
saying that would be good if they can't tolerate it in a boot?
Yeah, yeah. And too, if, like I say, if you've got a patient that says, oh yes, I can ambulate, and you say, okay, Mr. Smith, walk to the door and back, and they shuffle to the door and they shuffle back, and then you ask, well, how many times do you really do that a day? So there's a big difference in can you ambulate and do you ambulate? So if you've got a short stretch on and they're not ambulating, they're not getting the benefit of that calf muscle pump. So we really want to be sure that we're being safe with that. But another thing too, like I say, not only the cost savings, but being able to see your consistency in your wrap. And if it's something that they're going to keep on for a longer period of time rather than cutting it off, then you're making progress rather than backing up.
So what's the short wrap and the long wrap again?
The short stretch, that's like an Una boot.
Okay.
You know, like the Una boot.
Right.
Ours is Unaflex.
Okay.
And that comes either like just the Coban wrap,
Right.
or it comes with the medicated wrap too. Our little convenience pack comes with a zinc wrap, and we talk about that, how very soothing and all that can be to that surrounding skin. So you may or may not use that, or you can just get the Coban, the Unaflex by itself. But this, same thing. You can get this by itself, and you can get it with the absorbent padding as well. So you can do it as you could even put, if you wanted to, the zinc under this, you know, just depending on what your patient would need. Yeah.
And this is for, which is for which is for the patients that ambulate, and which is for the ones that don't?
The short stretch, the Unaflex, Unaboot, is for ambulatory patients only. And this is for ambulatory or non-ambulatory. Yeah. Yes.
I've had a couple of patients that said their doctors wrap their legs, boots up their thighs, and we've always stopped just below the knees.
Mhm.
Is that really recommended, and what would be the purpose of wrapping the thighs?
How do they walk? It's hard.
Well, how were they walking? I mean, carefully, you know, how are they walking? Wow. I mean, have you
I've
spoken
not
with them?
actually seen it on,
Uh-huh.
but this is what they're telling me. You know,
Yeah.
when I go out to the home, they say, well, the doctor wrapped all the way up to here.
Yeah. Well, now, you know, that's interesting because, you know, I spoke about my brother a minute ago who has the stocking. And for 3 years, he's had the stocking below the knee. The other day, he got knocked off of a ladder at Toys R Us with about 400 and some volts, and busted his knee up on that leg with the DVT. So I go up there that night to bandage his leg up and all that stuff, and of course he doesn't have his stocking on. So we go get his stocking, and his stocking comes all the way up to his thigh now, and I had never seen one of those. So, have you seen that
Yeah,
yet?
I've seen.
Yeah, yeah.
They're not popular with patients, they're not very compliant with them.
Right. So I'm sure my brother's was off the next day too.
Well, I wonder if that's what they're talking about, Hattie, is they have thigh-high tepos.
The thigh high, yeah.
Yeah, I mean,
that
I've
to
seen
me
those a
seems
lot.
like it would be, a little constricting in the thigh area, but
It can be if
They're
if they
actually
let it
constricting
roll
at the
down.
if they
knee.
let it roll down,
Yeah,
that's
at the
right.
knee.
Yeah,
Yeah.
so I guess the key to that would be to just be sure that they are watching and they know the risk and they know what to look for to make sure, that it stays in the right position. Yeah. Okay? Yes.
Neil, I'm getting a little mixed up with the vascular. I understand the Una boots, but I was under the impression with the venous, I'm sorry. I was under the impression that you were going toward with the arterial, not to do compression. I thought that's where you were going.
That's exactly right.
Okay.
You're exactly
I just
right.
wanted to make sure.
You are exactly
Okay.
right. Y'all heard what she said. If we've got arterial wounds, we are not compressing.
Right.
This is only with vascular wounds. You're
Okay.
exactly right.
I just
So
wanted to
what
make sure.
sort of prevention do you do for arterial circulation problems?
Quit smoking. Just those things, because when they've got the cardiac disease, a lot of times that is going to, because remember what it said, atherosclerosis was one of the main causes for that. So just preventing that as you can, exercise.
These are surgical patients, they can have, their families.
Certainly, if they can have that surgery to open up those vessels, a lot of times they can go through that.
Or
Restore.
pictures.
Show them the pictures. That's right. If it's one of those things that it can't be fixed surgically or does have an opportunity to be prevented, yes. But yes, and to your point about the surgery, certainly if we get a patient that has the surgery and that circulation has been restored, then yes, managing some of these wounds differently would be appropriate. But until that restorative surgery would be done, then just managing these wounds, just like we've talked about this morning.
Can you assist us, because I got a funny feeling all of us is gonna have an arterial ulcer with boots on. Now, calling this physician now, you've been doing these Una boots for a while, and assist us in making a call to the physician to say, oh, can I not put that Una boot on today?
If you have a patient, and I understand that you guys cannot make a diagnosis of what type of wound that is, and so if your physician is saying that this is a venous wound and you think it's an arterial, I think it's certainly worth some discussion to call and say, according to my assessment, this is what I'm seeing. And when I look at our guidelines that say this is the criteria for an arterial wound, I just want to make sure that we're doing the appropriate treatment. I mean, and ever so delicately with those physicians' egos. We know that we have to be. Yes, Pat, help.
Well, another inroad might be if the patient truly has an arterial wound, that Una boots can cause them immense pain.
Yes.
So that, you might start with, it's very painful to the patient. Could we try?
Yes, absolutely. And if you, like I say, that arterial wound, the pain associated with that, and that really motivates them to call too. If that physician is saying, do you know this is what I want to do, then maybe the patient can get involved as well with that physician.
So you just don't get the same kind of pain with the venous?
No. And really the pain from the arterial wound is just from the lack of blood flow, just that lack of oxygenated blood there, yes. That tissue is dying.
And I think in that case too, that would be a good thing for you to get the wound team involved, that we're getting up and ready. And that kind of, to say, well, our wound team has assessed this wound and we were thinking we might want to suggest a different kind of dressing. And that gives you some credibility behind what you're trying to assess. So, and the way you communicate that, I think, is very important too. So we're going to be doing something with that early in the year.
That'll be great. And, so many times that physician may welcome your thoughts on that.
Yeah, I think most of them
a lot of
do.
times we assume that the physicians know it all. And, there are a lot of physicians out there that you may not be a vascular doctor, who are seeing patients, and they really would like your feedback. They would like your recommendations and your thoughts, because really may not know. You know, we find that a lot. So don't just assume that that physician, unless it's one that you know, that really is gonna give you some, you know, pushback.
Especially if they're not being seen by a wound care specialist, a physician. They have the products that they liked and have used for all, you know, and they maybe just aren't up on all the new ways to treat things, and so I think they may not have looked at the most recent literature, and that's the kind of thing that we're gonna be able to bring to them, I think.
Yes.
You seem to have them in a dependent position with the arterial ulcers, but most of our patients, they might just then sit there all day. I mean, wouldn't the venous flow be bad as well, more than likely? And so maybe sometimes where they put it up for a few minutes and then down and then.
And there certainly is mixed cases as well, and that's another thing that you'll see. And those are the ones that are most difficult to manage, the ones that have the mixed venous and arterial.
So it's fine to let them know that they don't need to sit there.
Oh, yeah, and that's
Alternate them.
yes, exactly. That and that pain really would drive their position. I mean, if they're able, if it makes them feel better to sit dangling, then by all means do that. But if they're able to move, and certainly we want them to move as much as they can, but their pain would really motivate their position. Yeah.
Especially in venous stasis ulcers, a muscle pump is what helps get, you know,
So
the
that
blood
walking
flowing
is really
back,
gonna,
so-
that movement is really gonna help to keep that flow going.
Or that,
Yeah.
wasn't good for the foot.
Yes,
if you can't
that's
move
right.
well.
Sitting still, exactly right. Those flexing that foot and getting that pump to work, even if they're not walking. Oh, these are very good questions.
Tammy, is the, part of the diagnosis, other than just the type of wound, what it looks like, can they not do that ABI to see if they're venous or arterial?
Sure, and that is optional,
Because I think Mary Ann can do that too, if I'm not mistaken.
maybe so.
What is the ABI?
Can you explain what ABI is? I don't think I've.
That's arterial brachial index, and that just is really gonna tell you whether, and it's a whole lot, a formula that you follow according to the blood pressure here and at the leg, and sometimes they do toe pressures. So it's a calculation to let you know, is that patient appropriate for compression?
Just the difference in pressures between the arm and
Yeah,
leg.
yeah. And so there's a formula for that, and, you know, if it, and a lot of times they'll do it at the physician's office, you know, but you can certainly be done out in the field. It certainly can be.
So you can have an ABI that say you're appropriate for a Una boot,
Mhm.
but you can also have a venous stasis also. Not venous, I'm sorry. Let me get it together, arterial.
And if you've got a true arterial wound, probably your ABI is gonna score way too low to say that you qualify. You see what I'm saying? So that pressure, remember, if we don't have a lot of blood flow down there, that pressure is not gonna be great at all. Because they're doing pressure on the extremity, sometimes on the toes. Okay, so that score would let you know. But if you follow, just to get a more generalized, without doing the ABI, on your assessment end, if you can look at the characteristics here and look at all of those things that we talked about, where the wound is, the type of wound edges, the wound bed, the pulses, you know, a lot of those things can give you a good indication of what you're dealing with. Does that help? Yes.
I just want to add also, maybe everybody doesn't know that only venous stasis ulcers are scored on the OASIS and not the arterial ulcers. Diabetic ulcers and arterial ulcers aren't scored on the OASIS.
Okay.
Only like decubitus ulcers, surgical, and venous stasis wounds. Anything
Okay.
arterial, even though it's an ulcer,
Right.
it's scored on the OASIS.
It's not
Just so everybody
documented
knows.
as such on the OASIS.
Mhm.
Okay. So would that be considered a lesion?
It's just a lesion.
Just a lesion.
Any arterial wound is
Uh-huh.
just a lesion.
Okay. Did y'all hear that? She was talking about arterial wounds on the OASIS? Okay. All righty.
And next week, we'll talk about OASIS and documenting and how to do that accurately. So, thank you very much. Please leave your evaluations at the back or the front.
Uh-huh.